So we have overall the cause can be bacterial, viral, or fungal. And we could have presentation like sepsis, septicemia-like process, the inflammatory response causing the various non-specific symptoms. It can be localized to the lung or the brain. Meningitis can be there. Otitis media as a presenting feature is not common in the first few weeks. Diarrheal disease and urinary tract infection can overlap as well. A baby with UTI can present with diarrhea. Osteomyelitis, septic arthritis as well can happen, especially in a baby who had interventions in the newborn period. I've seen 2 or 3 babies, so only intervention was IV fluids for 24 hours because of hypoglycemia, and then after 2-3 weeks they come with septic arthritis. So it's a totally avoidable thing if the team practices hand hygiene and infection control when they handle the IV lines. Conjunctival and orbital cellulitis, again, gonococcal ophthalmia neonatorum is very serious and it needs systemic third generation cephalosporin treatment. So very important that we look at it in the gram stain where there is inflammation. And cellulitis and umbilical sepsis is very important because if you don't pick it up and treat it adequately, so we say the inflammation around the umbilicus, if it's more than 1 centimeter and there is pus, you have to treat with IV antibiotics. And obviously, if you don't treat it adequately, it can predispose to portal hypertension in the future. Now, a few slides on perinatal viral infections. Obviously, I'll not be covering all of them, but looking at some of the important ones, especially CMV and herpes. The cytomegalovirus can be congenital or acquired, and parvovirus infections leads to severe marrow suppression, anemia, and hydrops. So when you have hydrops, that's one of the differential diagnoses. Adenovirus can cause a congenital pneumonia, and enterovirus or parechovirus infections, Coxsackie virus, they can all have high fever. So these 3 viral infections are well known to cause high-grade fever, which can be persistent even in the newborns. And the Coxsackie virus and echovirus can specifically present with myocarditis. So you have a baby coming with upper respiratory infection-like presentation, suddenly starts worsening, shock-like presentation, feeble heartbeat, and you may consider an ECG and echo in these cases. So myocarditis is a very important and serious factor in these infections. Chickenpox, obviously, we know there is timings according to the mother's immunity, and if the mother has chickenpox in the 5 to 7 days just before delivery and in the first few days after delivery, the baby has a significant risk. So herpes simplex as well, very important to monitor. I'll be discussing that in a little more detail. HIV, we have reducing numbers, and we need caution. Very important that the antenatal booking bloods are always reviewed. And of course, if the mother has a procedure, they would be doing it again. But obviously, from our side, we need to be cautious because there is prevention methods now, and we can use the prophylactic medicines to reduce the risk, and also cesarean section where it's possible. Polio, of course, is not a perinatal infection anymore, and it's almost vanishing. India has eradicated polio, but it's still there in Pakistan and other places in South Asia, so we have to be careful. Previously, we used to talk of in utero infections with the TORCH acronym, so toxoplasmosis, O for others, R for rubella, CMV, and herpes. So we used to do torch titers, so blindly send for all of these, but it's neither cost effective nor targeted. So currently the approach is that we look at the clinical signs and symptoms, what is the most likely infection in this category, and then look specifically the tests that are appropriate for them. So don't do overarching broad testing. Obviously, many questions come up about serology. Nowadays, we prefer PCR where possible. But if you are doing serology, IgG is non-specific and usually it reflects the mother's past infection. IgM is more specific, but often it takes time to come up, and you may not have it positive as well. So in terms of mother to child transmission, we have either in utero transmission, peripartum or intrapartum, which happens more with the hepatitis B, and postnatal, especially from breastfeeding. CMV could have any of these patterns. So looking at this, I mean, you'll have a copy of the slides. So, and this is from Cloherty as well. So you have different examples of where you can do the DNA or RNA PCR and culture for the bugs. So I'm not going into detail, but just to give you a summary that this table doesn't give much of IgG, IgM, and the PCR is more expensive and it's quicker turnaround time. So if you do it, probably you'll get the result quicker. So look at the bug you're thinking about and do the specific test for it. If you're thinking of CMV, obviously urine PCR is sensitive. If you're thinking of herpes, I mean, skin, eye, mucous membrane scrapings can be sent for PCR, and same with varicella. Cytomegalovirus is a double-stranded enveloped DNA herpes virus, and typically it's called cytomegalo because of the intranuclear and cytoplasmic inclusion bodies. It's the most common congenital viral infections. In the developing countries, most of the adults are already immune or they have been exposed before because we have overcrowding. 90% of the adults have antibodies, and there may be a 3 to 4% risk of pregnant women getting their first infection in US, but that infection rate probably is lower in India, maybe around the 1% mark. And if the mother has infection as a primary infection, it's a high risk setting for the fetus. The fetal transmission rate is 30 to 40%. If she gets it as a secondary infection, she has been exposed before, she has partial immunity, then there is a lower transmission rate. Infants who acquire the congenital CMV in the setting of no pre-existing infection are more likely to be symptomatic and they have long-term sequelae. Hearing loss obviously can happen in both groups, whether the mother had previous infection or not. So it's very important that we monitor the hearing later on in these babies as well, where you have identified the risk. Transmission to the fetus, depending on when the infection is activated in the mother, it can happen either early in pregnancy or later, but the earlier it happens, the higher the risk of severe disease. And congenital CMV is seen in approximately 0.5 to 1% of all live births in the US. So I said 1 to 3% of the mothers have primary infection. And so because 30 to 40% of them can have the baby affected, that's the percentage here. And there is a significant risk of sensory neural hearing loss and developmental delay. So many of the developmental delays that we don't identify having any factor could actually be viral infection, especially CMV related. And previously, transfusion used to cause CMV infection, but now we use leukodepleted blood products in the newborn. So removing the WBC is going to reduce the risk of CMV. Freezing, like fresh frozen plasma, for example, doesn't carry the risk as well. Breast milk is an important factor. Mother can get exposed after the baby is born, and when she's breastfeeding, the infection can transmit. Donor breast milk also can be a carrier, and as you're screening for CMV, flash pasteurization reduces the risk, and freezing the milk reduces the risk as well. So very important that if you are using a milk bank, be aware of these risks. And remember, this CMV acquired from breast milk is a very big problem in the extreme premature babies, and it presents as sepsis or NEC after a few weeks. So in terms of how the CMV infection can present in the perinatal period, we have the congenital symptomatic CMV where it's an acute sepsis-like presentation right from birth, or it can be a non-acute presentation with microcephaly. You have cranial ultrasound done because you have IUGR with microcephaly, possibly liver function abnormalities. Then you see periventricular calcifications. The baby then goes on to develop deafness, and chorioretinitis may be either there at birth or it may progress. So it's important to monitor both the visual and hearing in these babies for longer term. The baby may have an asymptomatic congenital infection if it's, just hold on 1 second. Dr. Ala, I'll call you in 15. I'm in a meeting. I'll call after half an hour. Okay, thank you. So postnatally acquired CMV infection can have clinical symptoms at 4 to 12 weeks. This is the group I mentioned in a extreme premature baby presenting with pancytopenia or thrombocytopenia, skin rash, liver function abnormalities, and sepsis-like presentation. And it's also one of the NEC mimics. So the baby has NEC-like presentation as well. So if you can't find out a clear reason, it's not responding to antibiotics, it could be CMV, and testing the urine PCR is very important for that. So we also have RSV-like presentation, which can be severe in some babies. It can also lead to bronchiolitis obliterans, like picture in the premature babies, or some babies with BPD have persisting symptoms again because they have acquired CMV. Transfusion, I told you the risk is lower because of the leukodepleted transfusions used. And if it does happen, it's usually 4 to 12 weeks after transfusion. So Some units have a policy to check their CMV status at birth in the extreme premature babies, but I'm not sure if it's cost effective. The mother's serology could be looked at if she is IgG positive, the risk is lower for the baby. And if you are using breast milk, flash pasteurization or use of the frozen milk reduces the risk. So you could consider doing that for the extreme premature babies in the first few weeks. The diagnosis is made by the PCR on the blood, saliva, or urine. You can also use a shell vial culture, which gives you the results within 2 to 3 days. And IgG, IgM, as I said, is not used frequently, though that may be the only test available to you. If IgM is positive in a premature baby, it usually suggests a past infection and the symptoms could be related to that. Or if the baby who was having only IgG at birth, if the seroconvert later, it may indicate postnatal CMV. Ultrasound MRI could help for the CNS sequelae assessment. And even the babies with normal brain imaging may have sequelae, especially hearing loss can happen. And if there is neurologic involvement, we should consider antiviral treatment. In the extreme premature babies, if you do pick up CMV infection, sometimes we give ganciclovir, but these are babies who are already immunocompromised, and having a pancytopenia or neutropenia secondary to the ganciclovir is not easy. After the initial period of IV ganciclovir, oral ganciclovir can be given, vial ganciclovir, and we have to monitor for neutropenia. I have only treated a few babies with ganciclovir, and a couple of them had neutropenia, which was persistent. We had to stop the treatment. And obviously, in the asymptomatic babies, not with the sepsis-like presentation, just giving it for hearing or chorioretinitis symptoms to prevent it is difficult. So mostly it's the small babies with the early symptoms who get treated, this group. Coming to perinatal herpes virus, herpes is a double-stranded DNA virus with two distinct types, herpes simplex 1 and 2. Previously, we used to say type 2 was related to genital infection, but currently we see type 1 associated with both genital and non-genital symptoms. The transmission usually is intrapartum, and that's why there is a protection of cesarean section before the membrane rupture or within 4 hours if possible, if there is active genital lesions. Antenatal and postnatal infections are less common. The clinical syndromes, we have 3 types. The skin, eye, and mucocutaneous, which has the best prognosis. It's commonest and 50% of the cases. So you have a high index of suspicion if you see vesicular lesions in the newborn period. It's localized sometimes or more generalized, and the baby may have a sepsis-like presentation as well. So if they have meningoencephalitis with neurological concerns, seizures, high fever, they may present with hypotonia, lethargy as well. If we start treatment early, the prognosis is better than 30% mortality if you don't treat it early enough. Of course, the risk of sequelae is there with the herpes meningoencephalitis, and we have specific EEG findings and MRI findings with temporal lobe dominance as well. Disseminated infection comes as a sepsis-like presentation, DIC, sepsis, hepatitis, and shock. So these babies present by 12 to 14 days, and if you have any skin rash followed by these features, you have to cover with herpes. So add herpes to your testing panel if the baby has lethargy, seizures, hypotonia, irritability. High-grade fever is not typical in newborns otherwise, so mostly it's viral, and herpes is one of the DD. Shock, DIZ, hepatitis, and if they have vesicular skin lesions or there's a history of genital herpes or other herpes infections in the mother. Cold sores are fairly common as well, and they often get activated after the delivery. Viral isolation or PCR detection of the viral DNA on the swabs is very important. Usually we do swabs from the mouth, nasopharynx, conjunctiva, and anus for either the culture or PCR. And if there are skin vesicles, you can do the scraping. And CSF PCR is very important if you're doing a lumbar puncture as well. The treatment is IV acyclovir. We use a higher dose, which is 60 milligram per kilogram per day in 3 divided doses. And remember that acyclovir is fully excreted in the kidney, and crystallizing in the urine is a common complication. So ensure there is adequate hydration as well. The duration of therapy for skin, eye, mucocutaneous disease is 14 days, and at least 21 days for the CNS or disseminated disease. Oral acyclovir suppressive therapy is also recommended these days because of the high risk of recurrence. So you give oral treatment for 6 months for HSV infection, which is of any type, which is confirmed. There is also this consideration that the mother has genital infection. What do we do next? So we have the primary infection where this is the first time she has and the risk is much higher. So you consider CS if she presents early enough before 4 hours rupture of membrane. And at 24 hours, you swab the baby. And if symptoms or the swabs are positive, then you treat with the cyclovir. If it's a recurrent infection, you don't consider CS, but you consider swabbing the infant and treat if symptoms are swab positive.